We've talked a lot about healthcare on this podcast, and we've heard a lot of good ideas for making healthcare better. But sometimes it isn't about fixing the one big thing, but rather the thousands of smaller things that are broken. Hey everybody, this is Chris Brandt here with another FUTR podcast. Today I have with me Dr. Craig Joseph, author of Designing for Health, the Human-Centered Approach, and Chief Medical Officer of Nordic Consulting Partners that helps healthcare organizations improve their processes to make the people they serve healthier. So let's talk with Craig about what needs fixing in healthcare and what inspires him. Welcome, Craig.
Thank you. I'm excited to be here.
I'm excited to have you because I think this is such a timely topic, not the least of which of me recently being hospitalized for a bit, but it was an interesting perspective. So I'm really excited to talk to you. But could you give me a little bit of your background and like how you came to write this book and what you're up to?
Before I do that, let me just compliment you on your doggedness of making sure that you really understood what's going on in healthcare by getting admitted to the hospital. Takes a lot for someone to really investigate.
You need that dedication to the podcast.
Really. You've gone above and beyond, and I want to call that out for your audience. All right, a little bit about me. I'm a pediatrician. I practiced primary care pediatrics in the Detroit area for about 9 years. And then kind of made a big switch in my life and moved to Madison, Wisconsin to work for an electronic health records vendor. So this is a company that makes those EHRs that your doctors either love or hate, but mostly hate, let's be honest. And so that was kind of a big switch. It wasn't as big for me as a lot of people thought because my undergraduate degree was computer science. And so I was pretty comfortable kind of in that techie world, but it was really was kind of a good opportunity that I couldn't pass up. And it did kind of change my career trajectory because since then I've been helping out in one form or another hospitals and healthcare systems with the technology that their doctors and nurses and clerks and billing folks and scheduling folks and patients now even use. And so it's fun. It's every day is a little different, and I like solving problems and making it easier for people to become healthier.
Well, so you wrote, and here's where the plug comes in, Designing for Health, the Human-Centered Approach, which is really interesting. So I've been reading through it, and I like the, you kind of have little kind of case studies at the end of each chapter, which are really, like they help you really visualize the problem, which is interesting. But so you wrote this book, Designing for Health, which is, I see a lot of parallels to another book that I know is very influential for you, and that is sort of the psychology. It was when I read it the first time was the psychology of everyday things, and now it's the design of everyday things, which is just an absolutely epic book, and had a profound impact on me. Clearly had a bit of an impact on you as well. Could you talk a little bit about like how the book came together and like what you wanted to communicate?
Yeah. So you're referencing the book by Don Norman, the philosophy of everyday things, and subsequently the design of everyday things. And on the cover is a pitcher, like a coffee pitcher or pitcher of water, but that is impossible to actually use because if you were pouring it out, the water would be falling everywhere in addition to coming out of the spout. And one of the things that Don Norman talked about early in his book is doors, the design of doors. And this really kind of opened my mind to the concept of design. I always thought of design as interior decorating, like, this color goes with that color, and it would be cool if we made this room bigger or changed the door. And I have no skill set there. So I'm still in awe of people who can look at this blank canvas or even a filled canvas and come up with the concept of how it can work. But Don Norman talked in one of the beginning chapters of his first book about the design of doors. And one would think like there's not a lot probably to talk about a door. It's got a hinge and maybe a doorknob. And but he showed with real world pictures actually of doors that are poorly designed. And once you kind of understand what a good door is versus a bad door, your life has changed now because you're now judging every time you walk in or out of a room or a building. And my number one sign that a door is poorly designed is that there are instructions as to how to use the door.
Yes.
I shouldn't need instructions to use the door. So if I see pull or push, probably a poorly designed door. And the worst case is when you see it with a little sticky note, because then it's a bunch of people who tried to pull when they were supposed to push, or vice versa. And so doors should just work, and we should know how they work, and just inherently understand if there's a doorknob or a pull bar, I'm supposed to pull on that, and if there's a flat metal plate, I'm supposed to push on that.
Right.
The door will open in front of me. And so the impetus for writing the book with my co-author, who's smarter but not as good looking as I am, was to really say like, hey, there are some design principles that we all should understand, basically how humans think and process the world around us. And oftentimes, especially in healthcare, but probably in all aspects of our life, we wonder why people aren't doing what we want them to do. Right. Sometimes people are smoking and we don't want them to smoke. It's not healthy. But it's not just patients. Like we want doctors to order this medicine, but they seem to always order that old medicine that's not as useful now, or costs a lot more and is no more beneficial to the patient. And so, we wonder, why don't people do some of the things that we authorities, smarter people with more experience, want us to do? Sometimes it's not because we don't agree with the thoughts. It's just that it's the system in which we're living is designed to help make it difficult for us to do that thing. And so I've gone around the country and a little bit around the world and seen times where like, hey, we're wondering why the doctors won't use the order set, or we're wondering why our nurses won't document this thing the way we want them to. And when you dig down deep into it, you're like, you've made it complicated and difficult to do that. So it shouldn't be shocking that people don't do that. They find workarounds to it. Now, again, I'm not saying that everyone needs to do everything that they're told. Far from it. I'm the number one example of not doing everything I'm told. Hopefully, my boss is not listening to this. But when we want to kind of do the right thing and you've put roadblocks in our way, that's not a good idea. And that's really the premise of the book. Hey, just kind of understand these basic concepts of how people think at a 30,000-foot level, and then intentionally apply those to your next project or to your next software integration. And kind of think about it instead of doing what we often do, especially in healthcare. So we say, oh, we're putting in some new software or we're developing a new building for cardiologists.
Right.
How should it work? Oh, I know. Let's ask the chief of cardiology, the most important person in cardiology at our organization. Well, that's great, except for that chief has been practicing usually a very long time. Yeah. That chief hardly sees patients typically, because a lot of their time is spent in administration. Again, understandably so. Yeah. That chief usually has minions below them who kind of queue up everything and make everything perfect so that they can just spend their time doing quality things that they think are really important. Like not documenting the visit or ordering things. And so oftentimes we, in the healthcare system, we ask people how things should work, but we ask the wrong people.
Right. Well, and I remember like you had an example in your book of like, I think it was you taking your son to the doctor with a headache. And, they have this pre-filled, this list of all these potential ailments to check off, and she just goes right for the other box and just types it in.
Well, I was taking my daughter actually to a child neurology clinic at an academic medical center, right? And the medical assistant or nurse, whoever it was, said, why are you here? And I'm looking over her shoulder as she's typing in the computer because the software that they're using was the software I was helping to design and implement, and the company that I worked for. So I was very curious as to how she used it.
How's it working out?
Right. I want to know that. And so I'm watching her, and I said, we're here for headaches. We want to be evaluated by the child neurologist for headaches.
Yeah,
and
neurology and headaches. You think that'd be like a common thing.
She's got a list of 50 common diagnoses, and headache ain't on that list, right? and so she goes right to other, and then goes to a free text box. And so I said, "Do you not see a lot of patients here?" This was a kind of a stacked question. Do you not see a lot of patients here with headaches? And she goes, "Oh no, we see a lot of patients with headaches." I said, "But the system doesn't include headache as a common choice." And she went, "No." And just went about her business, not knowing that they could easily change that, and and so it's just one of those things where I'm not sure how that got missed, or that was a failure in multiple areas, because I asked her, how would you make this recommendation? How would you call this out to the bosses so that they can fix this for you? And she had no idea. Which was another kind of design flaw, because we all know we're going to make mistakes, and so we should make it easy to get feedback from people. Not all of it's going to be great, but much of it will be. Yeah. And that was a fix that would take 30 seconds if someone just knew about it. So that was fun, and I tried to put those little scenarios in there.
Yeah, I really enjoyed those. Those are fun. Those are fun little anecdotes that just really drove home the point. I mean, and I think it's interesting, because going back to the psychology design of everyday things, it talks, I can't, open a door without having that same, evaluation. It's the vertical bar I'm pulling, the horizontal bar I'm pushing, all that stuff. And when I get it wrong, it drives me nuts now. It's
nuts.
But another thing he talks about in that book is, sort of like decision fatigue and things like that, and sort of like the cognitive errors that people make. And that's kind of like what you're talking about here, I feel like, because it's like she's so used to being in a broken system, she just assumes everything's going to be broken, and that there's no way to fix it, and that she has no agency, right?
Correct. And often you're right.
Yeah, right.
often you're right. And so you'll find that, and this is, again, if you don't see a well-functioning system, it's really hard to envision it. It was hard when you just had horses to envision a car. Right. You couldn't ask, what would you want? I'd want more horses. That's what I would want. Right. You can't envision that. And so, same thing with a help desk system. And so, I've certainly seen that where it's difficult. We make it difficult for people to give us feedback. And then when they give us feedback, we ignore it. Or worse yet, we take action on it, but we don't close the loop. And so the person that made the suggestion doesn't know that we're considering it, and we're actually, operating off of that change and making an improvement. And so, adding transparency to that system really makes a big difference. And I learned that when I was on the software side, when I worked for a software vendor, because they had a homegrown help desk ticket, and it freaked me out when I first saw it. I was concerned, and I've told the story many times where I was maybe at the software company a week or two, and again, this is coming from a guy who had just finished practicing medicine for 9 years, and now is working with a bunch of small young children, seemingly, at a software company, and. I go to the restroom, and the door is closed, and there's a paper sign someone wrote, and it said one of the toilets flooded, and it said help desk ticket submitted. And I literally thought I was being punked. Like I thought they were making fun of the old guy, and I'm like, help desk ticket for a bathroom that kind of flooded or overflowed or something. But the culture of that organization was, and this wasn't actively happening, right? So it wasn't like the water was still coming. It had stopped. It just needed to be cleaned up and plunged or whatever. The culture was, we submit a help desk ticket for everything. Yeah. But the difference was, they did a lot of things that were really smart from a design perspective. One is they didn't require you to give information you didn't know the answer to. right? So oftentimes we see these stop signs on or we're not allowed to go.
Yeah.
There's an asterisk next to that
Yep.
to the box, right? And you must put something here, or you are not permitted to go on to the next step, right?
Right.
And oftentimes people don't know. Like, I don't know what the right answer is here, so they'll do what I do, which is put a period. Like, you wanted something, okay, here's your dot, or I'll put I don't know, or I'll put something that won't be helpful to you. So they didn't require any of that. They just basically said the more information you give us, the faster we're going to be able to respond. The other magic thing was transparency. When that ticket got submitted, I could see where it was. I could see which employee was sitting with that ticket. Right?
The unfortunate toilet
when,
fixing employee.
Well, that one was pretty straightforward, but there were others where you're like, I'm having a problem with my laptop. Like, is that an email problem, or is that a hardware problem? I don't know often, and do I submit it to this section or to that section? And what you could see was I would submit it to the wrong place, and instead of them sending it back to me saying like, this is not my problem, they just forwarded it on to the right place. Right. And like, that's a usable system. Like, yeah, I'm not the expert in sending this to the right place. I'm sorry. I do it infrequently. I really don't want to learn how to do it correctly, because I probably won't have to do it again for 3 years.
Yeah.
And in that time, I'm going to forget it anyway.
Yep.
So might as well just fix the problem for me instead of, it's one of those rare instances where I do want just the fish. I actually don't want to know how to fish.
Right.
So some of those, like, if you make it easy for people to give you feedback, they will give you feedback if they see that you're taking action and or being transparent about your actions. And so again, oftentimes it's not that I want, if I told you something, there's a process that we do and it's really dumb because we shouldn't have to do this and no one cares, and I'm still forced to ask this question of every patient that I admit. Sometimes there is a reason.
Yeah.
Sometimes it may not be a reason we agree with, but the government or the insurance company or someone says there's a rule. And so getting back to me as the issuer of that request and saying, hey, we agree with you. This is really not helpful. However, we can't get rid of it because of X, Y, and Z. And so we just wanted you to know that.
Yeah.
Like, that is a great interaction. And now I know I should blame the government, not my
not the developer.
Not my IT leaders. Exactly.
It seems like there's a lot of just the basics that haven't been covered in healthcare. And like, you're kind of putting forth that there's a lot to be gained by fixing some of these small things. But, obviously there's some challenge with that too, because, when you start applying changes, you have to think, broadly to how that's going to scale across, the country or even the world, right? And so, I think that's got to be, kind of a challenging, place to be. Like, how do you solve these problems on a larger scale? But maybe they don't need to be. Maybe they, just act locally, and it'll turn out.
I think I was going to use the word counseling one of my children, but I don't think you ever really counsel your children. Maybe it was yelling. I don't know, but
it's a form
my
of
kids
counseling.
are maybe for me. My children are older, and so one of them has her own health insurance now. She's off of my health insurance plan, which is amazing and scary at the same time. And she was struggling. She was struggling with some stuff, and I happen to know a little about health insurance and the way healthcare system works in the United States. And I ultimately said to her, I think you just need to understand that no matter what you do, it's wrong, right? And she's like, how could you possibly say that? And I'm like, I'm much older than you, which is how I can say that, She's like, well, tell me, is it better to do A or B? And I'm like, just do one, and chances are excellent it won't work, and then you go to option B, Do I call the doctor's office when I get this bill that I think is wrong, or do I call the insurance? And my answer is yes. I don't know. It doesn't, whoever I call, in my experience, I needed to call the other one first. And so it's just random. Clinical decision support is there for physicians and nurses and in healthcare specifically to in some ways alleviate some of that. The concept of having too many decisions to make, being kind of anxious by decisions. I believe it was President Obama who had his clothes all like picked out for him. Like he did not want to waste time thinking about what suit he should wear. So he just pawned that off on someone else, right? The decision fatigue, he just, I got a lot of decisions. I'm going to make as few as possible and let someone else come up with this. And I think that's true a lot with physicians as well. And so, we talk about making it easy to do the right thing. Again, like pretty basic design principle, make it easy to do the right thing. Now, that's actually something that you can implement. As I go around the United States dealing with very sophisticated and complicated healthcare systems, oftentimes they say, well, that's not as easy as you say. And I'm like, no, it's actually super easy for me to implement, making it easy to do the right thing. The hard part is you telling me what the right thing is. Right. So most physicians, I would argue, who are admitting a patient to the hospital for community-acquired pneumonia are not infectious disease experts. They're, primary care docs or hospitalists who deal with a wide, range of like, hey, I just want to know what's the best antibiotic for right now for the hospital that I'm in, because you go from different states, you see different types of bacteria and viruses. And so that's a decision that ultimately most of us will say like, I'm happy to go with the flow, tell me what the right antibiotic is and I'll prescribe it. Well, that's a decision I probably don't have to make. Actually, I really don't want an answer to that question. What I really want is a set of orders that I can open up called community-acquired pneumonia, and it'll have all the things that I'm generally supposed to do, and I'll agree with most of them. And so, having the antibiotic or a small selection of antibiotics there, and then defaulting the right answers, right? Why should I have to click on one of the antibiotics? Why don't you click on the antibiotic that is the cheapest, that still works the best? And so it's already defaulted in, so I don't have to make, that's a decision I don't really need to make. Now, my patient's allergic to that class of antibiotics, I have a decision, right? Then I have to change something. And so there are always reasons not to do the quote unquote right thing. But I'm going to do the right thing most of the time because I want to. That's why we went into healthcare. That's almost why most of us kind of live in society. We want to do what the right thing is most of the time. Sometimes we disagree for a good reason. Sometimes we disagree for a not good reason. So we still have that agency. We still have that choice. The ability is always there to make other decisions, but make it easy for me to do the right thing. There's been lots of research that says, hey, when you started a new company, there's two ways of getting you into the retirement program, the 401k, right? One is to opt in, which means you're not in unless you tell us you want to be in.
Right.
But what happens if we flip that upside down and say, well, we assume you actually want to be in the retirement, in the 401k program. We're contributing as the employer some money to that, so it's your money plus our money.
Yeah.
We're going to assume you want to be in it unless you opt out of it.
Yeah.
Right?
Default choices.
Default choices. Make it easy to do the right thing is another way of saying that. So absolutely, a more sophisticated term is choice architecture. The grocery store uses it when they put the food that they want you to buy at
milk in the
eye
back.
level. Yep. We want stuff you want to buy at the eye level, stuff that we're a little less concerned if you buy it or not. Maybe the margin's not as great. That's going down lower or it's going further back. These are decisions that kind of are to some extent made for you. You think you're making all of the choices, but they're making it easy for you to do what's the right thing for them.
Yeah.
Maybe the right thing for you, but definitely the right thing for them. So
Right.
yeah, some of these little things, again, making it easy to do the right thing. I see order sets, again, sets of orders that doctors use for things that they do commonly or actually less commonly.
Yeah.
And just say, hey, why are there multiple choices here? I don't know what the right answer is. I'm just going to pick.
Right.
Well, it'd probably be better for the expert, the infectious disease specialist, to pick for me. Tell me like, well, most of the time, for most patients, for this diagnosis, this is the antibiotic that you want to use. Terrific. I'm not going to argue with that.
Or pharmacy.
Now,
Pharmacy, that's another discipline that you don't, is, I think, underappreciated in the world. Because when you're in the hospital, pharmacy can add a lot to the treatment.
Exactly right. And we talk about team-based care now, which is different, right? 50 years ago, the doctor was at the center. The doctor was the sun, and everyone, including many would say the patient, rotated around them. We're hopefully smarter now and know that, well, the doctor might still be the captain of the ship, but you still need a lot of people to run that ship. And so making sure that nurses and pharmacists and respiratory techs are all kind of on board. We're all communicating, letting them make decisions that they can make because they're smarter than we are. Mm-hmm. I remember vividly being told once when I was a pediatric resident at a children's hospital, hey, we need you to go draw blood from this patient. And I said, why? I don't normally get that kind of request. Why do you want me to do that? Well, the phlebotomist who does it all day, every day was unsuccessful. And I'm like, this makes no sense whatsoever. Unfortunately, the buck did stop with me as the resident. But it's just one of those things where you're like, we see this sometimes where a pharmacist has to call and say, hey, doc, did you know that this medicine you prescribed is not effective at this dose? Or are you hopefully this doesn't happen very often, but, are you trying to kill the patient? Because that dose that you wanted was very high. And we, much of the time there's just minor things. And it'd be great if we can just kind of work as a team and like, yes, no, I did not mean for that pill to be squeezed through the IV tube. Yeah, I was not trying to kill my patient. I made a mistake and thank you for calling me, but just fix it. And I think we're getting better and better at just fixing it. Yeah. Kind of bypassing the kind of step of, well, we wanted to make sure you weren't trying to kill the patient.
Right. Well, and on that, I mean, there is medical mistakes do create a lot of bad outcomes. And, when I look at the state of healthcare right now and physicians and, having just spent a lot of time talking to physicians and sort of hearing some of their pain points, in preparation for this, because I did my deep, learning on this.
You're the man.
They're being squeezed a lot because, there's not enough doctors to go around because there's not enough residency programs, but there's not enough residency programs because some residency programs like internal medicine and things like that are underfilled, whereas some of the, like the specialty ones that are, more pay better are very full. And, and a lot of it comes down to like procedures and whether or not you can do procedures, because there's a very straightforward way to get paid on procedures. But, the doctors who have to do more, the research and the brainstorming and things like that, there's not a procedure code to go along with it. So they're some of them are struggling to make ends meet. And, like internal medicine, the primary care physicians, it's tough to on them because they don't have those kind of procedure codes to put in. They're not doing a lot of that stuff. So they're literally struggling to pay their bills in some cases, And so the way they fix that is like, we'll get these immediate care centers. So we'll take some of that load off of you. And then, you'll have more time to do this. But then it's like all this insurance billing and all this other, non-medical stuff that they're doing. So that by the time they get to see a patient, they have such a limited amount of time. They're stressed out of their minds about doing it. And so, like, you could see how easy it would be to make mistakes, which I think really reinforces what you're doing in that, taking away some of these barriers to making the right decisions is going to be really important in this kind of context because it helps not make those kinds of mistakes. It helps them get through some of the, unvaluable kind of time that they spend faster.
Yeah, you've hit the nail on the head with some of our payment schemes here in the United States, and certainly we're endeavoring to make that better, but it's difficult and it's slow, and there's lots of constituents that want to protect their piece of the pie. But yeah, there's a good question of there's a lot of things that physicians do that one wonders why they do it, right? And so we talk about. Public health screening, women are supposed to get
mammograms.
I'm now blanking. Thank you. This is what happens when you're a pediatrician and never order mammograms. Women should get mammograms, and there's lots of other things. Everyone should be getting colonoscopies or at least checking for colon cancer screening one way or another. And often that doesn't happen. And one reason is, well, traditionally it only happened when you came to visit the doctor. When you came to visit us, for whatever reason, you had a sore throat or your annual physical, we would look and go, oh, you haven't had a colon cancer screening for a while. Every 10 years you should be doing that, or whatever it is for, that. And the question a lot of people are asking now is, well, why is that? Why is it that we need to only do that during an office visit? Why can't we use our fancy electronic health records to look for everyone who's in our system, who's between this age and hasn't had this screening in so long, and then send them not only a card, because that's what we get a lot of, is like, hey, here's a letter telling you that you need this. Why don't we just order it? Why don't we just order it? And in fact, why do we need a physician? As you just pointed out, they seem to be in high demand and should be working on other things. Do we really need a physician to order this test? Certainly we need a name, and we need to know who the result is going to go to, for sure. But can't the healthcare system just kind of take responsibility for ordering it and making sure it's going through? And so there are some things where we kind of have still that kind of paternalistic attitude of, well, the doctor knows if you need a colon cancer screening. Yeah, well, the doctor knows, and so does this junior high student over here who can read that you need to have a colon cancer screening.
You don't even really need a person to do it. You can quite just scan the records and automatically send it out.
Right. Again, going back to that principle of making it easy to do the right thing. That's if the right thing as a patient is for me to get the colon cancer screening, then make it easy, for the love of God. Don't make me schedule an appointment. Don't make me, have to call the office for an order. Just let the order happen. Someone should order it, and then someone should make it very easy for me to schedule. And it should be, why are we not doing these things on the weekends? Why are we not doing them
after hours?
At other times? There are places. Absolutely. For people that are working during the day, that's a major problem. I have to take a half a day or a day off for that kind of a thing, and it doesn't happen. And it's in our best interest. It's in everyone's best interest to get that done, right? It's not just in the patient's best interest, but certainly we don't want to spend as much money as we do in the United States. We're among the top, if not the top, of all advanced nations in terms of how much money we spend on healthcare. It's much
with worse
better.
results.
It's much better. Right, with worse results.
That's
right.
a kicker.
So, it's better for all of us. I'll pay less for my health insurance, and you'll pay less for your health insurance if we can catch cancer early.
Right.
If we can prevent the long-term of complications of high blood pressure, it's going to save someone's life. That's great, but it's also going to save all of us money too, and that's also great. And that money can then be used for other things. And so, I think whether we're talking about an electronic health record or technology or the way a hospital runs or the way the whole healthcare system runs, there's lots of opportunities to kind of think intentionally about applying some of these basic design principles and making things better.
Yeah, well, and I like your perspective on it too, because you're kind of focused on the end user, like the end user's perspective, right? And like you were mentioning a couple things there, sort of like getting the annual mammograms and and PAP screenings and stuff like that. When I talk to my wife, for example, she's like, there's got to be a better way to do a mammogram screening rather than just taking these plates and smashing, the breast tissue in there. And like PAP screenings, like, taking a portion of the cervix without any anesthetic too, which, is by all accounts a very sensitive area, right? I mean, there's a lot of things that we just ignore for, certain segments of the population that makes them more reluctant to go and do some of these things, I think, as well. So it's kind of a combination, and then there's a financial incentive in there. It's like, well, we don't have to buy this special X-ray machine that's dedicated to mammography. We just want to use the one we use for other things, and we don't want to have to pay for anesthetic for this procedure. It's why would we do that? So there's a lot of like perverse incentives for everybody, but I think you're getting to the point of like let's talk to the point at which this is happening and get the feedback from those people, like being in the field and seeing how this is applying in real life and seeing how we can make those things better, right? I really like that perspective.
Yeah, and we quote someone who talks about an innovation safari. As a physician who's taken some of his leaders at various hospitals and various companies and taken them to other industries, right? So in healthcare, we're kind of used to, we're going to go over to this hospital across the state or across the country and see how they do this thing. And that's often helpful, and you can learn things. But you can also learn things by going to a factory that makes cars. Or a manufacturer that does something and kind of take some of those lessons back and apply them to healthcare. So, one of them, like you said, making sure you know who the user is and make sure that you're trying to help them. And to some extent, that's by identifying the right user. I earlier was made disparaging remarks about the cardiology chief. I apologize to them about that, but I stand by those remarks. They're probably the wrong user to ask how a cardiology system should run. So certainly we want to find those people that you do it every day and ask them and understand what they need. However, it's not just ask them what they want and give it to them. Because again, Henry Ford would be delivering more horses if he asked what people wanted and then delivered that to him. So you need to understand their problem, but then you need to offer a solution which they may not even have contemplated. How could they? And so
you don't need the horses; you need a horse equivalent.
Right. Oh, that's exactly right. I've been the chief medical information officer for a bunch of hospitals and healthcare systems, and that just means I'm the chief doctor geek. And oftentimes doctors would come to me and they say, "Hey, listen, I need a new order set, or I need this new functionality from this particular software vendor." And I'd say, hey, sounds like you're telling me that about a solution. I'm really not interested in hearing your solutions. I'm interested in hearing your problems.
Right.
So why not, instead of telling me you need a new order set, tell me what the problem is. Oh, well, the problem is that I can't find this thing or that thing, and whenever I need it, it's not there. And I'm like, okay, we could do this. Oh, I didn't know that. No, I know you didn't know that. That's your job is not to know that. Your job is to see patients and help them. My job is to help you. So I know that. And so when you come to me with a problem, I can help you, point out sometimes solutions you never thought existed. So hence you would never, ever ask me for.
Right.
So sometimes they come with a solution and they're right, but I'd say more times than not, it's not the best solution, and they're happier when I kind of intervene and try and take it back a couple of steps. And so it is important to ask users what they need or what they think they need, what they want, but it's also important to observe and then understand, well, why are you doing that? Hey, we have this form. We need you to make this form into the computer so we can get rid of this piece of paper.
Right.
And I'm like, well, I love to get rid of pieces of paper. So let me help you with this. Why do you have this form? We've always had this form. Okay, but why? Why? What's here that? Well, we just need it to go from here to there, and I'm like, well, you don't now because of the technology we have. Like, you don't need. So again, hey, what's the problem this form's trying to solve? Can I solve that in a better way? Or more often than not, it's not solving any problem whatsoever. It's just a dumb piece of paper, and we just keep it around because we keep it around. And,
right. Yeah. Well, and I think that's important because, in technology, if you don't have those kind of conversations, you get a very kludgy project with lots of bolted on stuff that doesn't make any sense, and then it becomes unmaintainable and unsustainable.
100%. And it's just common. Like, if you've done something the same way for decades, you're not generally, as we humans are not kind of built to kind of question that. We're like, well, it's worked. It's worked, and this is great, but do we still need it? Why did we start it back then? Oh, there was a rule back then that we don't have now.
But you're going to eliminate that person's job to throw away all those sheets of paper.
Well, it might, but we hopefully can find another job for them that's more meaningful. When I first joined this EHR vendor, I was at a go live at a major children's hospital, and I was called to a fight, and the fight it wasn't actually a physical altercation, but I think given a few more minutes, it might have been. The blood bank didn't want to send up blood because they didn't have a form that they absolutely needed, and that's a problem. So we need to resolve that very quickly. And there's all kinds of regulations and laws about blood, which there should be. And so the argument ultimately boiled down to the blood bank saying, we need this form with this physician's signature on it, and we never send out this blood without the form and this physician's signature on it. And then when I looked at the physicians, they said, we don't know what this form is that you're talking about. We have never filled it out. We have never signed it. And so there was an impasse there. Ultimately, it turned out that the unit clerk was signing this form for the last 10 years. Right?
And he retired.
A unit clerk. No. We had moved from paper to electronic. So that's why this kind of had come up. This form clearly held no essential information because a unit clerk, essentially the secretary of the floor, was filling it out on behalf of the physician and was scrawling a physician name or something like that there. And so, we were able to get rid of that form. Because we were able to convince the blood bank folks that in fact they were getting all the information, and it was coming from, instead of being transcribed from the chart by a clerk, it was actually coming from the physician. And so it was a win. It was a win for all. But again, you don't think about that, and that's again one of the benefits of doing that, as you talked about, kind of walking around and seeing how people are doing their job, just observing. You find these things where everyone thinks it's functioning great, and when you start asking questions no one has answers to, it's awkward. But it reminds me of Jack Welch, who said that he practiced. Someone asked him about his management philosophy, and he said, "I do management by walking around." Right? And again, the point is, hey, it's one thing for me to hear what my chief financial officer thinks and my chief operating officer thinks, and they're going to continue to tell me what's going on. But it's very helpful for me to go to the factory floor and just walk around and ask questions.
Yeah. Tell me a little bit about what Nordic Consulting Partners does.
Yeah, thanks for asking. So we're, as you mentioned, that word consulting. So we're healthcare management consultants. Kind of started off just helping with one electronic health record, and we became known as really having the smartest people about this one big major electronic health record that a lot of people have used and still use. And we've expanded since then. So we not only help with that electronic health record vendor, but with other EHRs. And then our customers were asking us, hey, can you help us with some revenue cycle stuff? So, hey, we're not bringing in the money, or we think we're supposed to, we're not billing the way we're supposed to be billing. And so we've got some of those expertise. And then we went outside the US, and so now we're in Canada and Europe and soon to be the Middle East. But basically we are problem solvers. And so we look for, again, it's much more exciting for us, and I think helpful for our clients when they come to us with a problem and not a solution. Right. Sometimes they still come to us with solutions like, hey, we need 3 experts for 9 months to help us get down from multiple billing offices to one single billing office. That was a common refrain. Yeah. Now we're hearing more of, hey, we're thinking about combining our billing offices into one to make it easier for our patients to get more information about their bills and to make it easier for us to manage that whole process. How do you think that should work? Yeah. And so that's what a consultant does, is kind of say, well, we've done this a bunch of times, and we've seen it done well and not so well, and we've seen the common reasons and the uncommon reasons for doing something, and so we can kind of bring that more global perspective to some of these questions and help out our clients, again, which are typically large healthcare systems and hospital systems in the US, Canada, Europe.
Yeah, it sounds like really necessary work, so I appreciate that you're doing that. So like, what's next for you?
I got curing cancer. That's on my list.
That's a good one.
Yeah. Then after that, it's going to be world peace, Chris.
Okay. I'll take those.
Now, I have an idea. I'm not doing either of those. I mean, let me be clear. I would love to do those 2 things, but I feel like I am probably not best equipped to handle the curing of cancer or the getting of world peace. I'm actually interested in now something called de-implementation or de-adoption.
Okay.
And this is an interesting concept to me. Sometimes we find things in healthcare that we thought were really smart to do, but now we know it's actually, there's no evidence that it's helpful, or even worse, sometimes like, ooh, we did that thing, it's harmful. Right. I'll give you one example. Ordering EKGs or electrocardiograms before patients, older patients typically, go for any type of operation, non-cardiac. So imagine you're going to get your knee replaced and you've never had a heart problem before. It's not uncommon in the United States. In fact, I'd say it's very common that your orthopedic surgeon is going to do your knee replacement, is going to order an EKG.
Right.
And if you were to ask why would you do that before I have this knee replacement? I never had a heart problem, never seen a cardiologist. Well, we want to be sure that everything's okay, and it's just an EKG, and it doesn't even hurt you, right? It's just a bunch of sticky pads, and it literally takes a minute. It's
I do find those sticky pads very painful to pull off. So I will say
I am with you 100%, but I'm trying to sell this thing, Chris. Help me sell it.
Okay. I'm helping you sell it.
And so what's the harm? It's a cheap thing, and if we discover a problem before we put you under anesthesia, that's a good thing. Well, the problem is that oftentimes we discover lots of things, but few of them are actually clinically significant. And so what happens is, a good chunk of the time, there's something there. But the orthopedic surgeon is not an expert at looking at EKGs, and so they refer you to a cardiologist. And then that takes time to get to see the cardiologist, and the cardiologist says, well, this is probably nothing, but we probably want to do an echo or some more expensive or invasive test just to be sure, because we don't want to find it. And so again, sometimes they find something, but more commonly they don't, and it wastes time and money. And sometimes, again, you get a procedure, you end up getting a diagnostic study that is actually harmful to you. Oh, we're just going to do the study, we need some dye. Okay, well, you've never had dye before, but now we find out you're allergic after we gave it to you, and now your kidneys are shutting down, and so we're going to have to put you in the hospital. Again, all because you wanted to get your knee replaced. And so the question is, how do we convince doctors to stop doing these things that they've been doing for decades? Because now we know that there's little evidence for that kind of that thing. How do we do the opposite of implementing? De-implementation. And it's not as simple as, hey, doctor, stop doing that.
Right.
Because we don't do that, and it's a lot easier for us. Inertia is just to keep going. Plus, we all have stories after we've been practicing long enough. Like, well, let me tell you. I know I've ordered this EKG 8,000 times, but let me tell you about the one time that I ordered it. That this patient, was going to have a hard time in the surgery, and so for that one time. I want to order it now for everyone. And again, totally understand that's the way we humans think.
And malpractice insurance has gotten very expensive too.
Correct. And so there are a lot of incentives, I would call them perverse incentives, to kind of keep doing some of these things. And so that's an idea that I'm playing around with, but don't tell anyone, because it's secret. It's between you and me, Chris. All right?
And all the listeners.
No. What? Listeners? I thought we were just having a conversation. You're confusing me now, Chris.
Yes.
No.
Yes, this is the covert operation to steal your ideas.
It's working. It's successful.
It's working. Yes. Well, I think it's a little harder to implement some of those ideas. It's in the devil's in the details, right?
Correct.
Well, I really it's fascinating stuff, and I want to just say go read the book too, Designing for Health. Actually, I know there's a lot of other reasons to write books, but I found some of the stories in here really interesting, and if you're interested in healthcare, it's worth a read. So.
Yeah, awesome, and you can get it on Amazon if you're interested, and
I'll put up a link.
Yeah, that'd be great. Love for people to read it, and I always am looking for feedback, but only if it's positive, Chris. I'm only interested in positive feedback. I'm very sensitive to negative feedback, and I would be scared about that.
All right. Well, we won't give any negative feedback because
Thank you.
The internet never gives negative
It's all
feedback.
positivity and love on the internet.
YouTube comments are the best. They're just a font of positivity.
It's the great humanity right there. Yes, you and I agree.
Well, thanks so much for coming on. Thanks so much for doing what you do, because I think, improving the healthcare system is, a Sisyphean task, but much needed for sure. So thank you for doing what you do and appreciate you being on.
Thanks for having me. It was fun.
Thanks for watching. I'd love to hear from you in the comments. And if you could, give us a like, subscribe, share with your friends and all the people you know. And I will see you in the next one.